Hi, today I'm going to present to you the study Testosterone Patch for the Treatment of Hypoactive Sexual Desire Disorder in Naturally Menopausal Women, the results from the Intimate NM1 study. The study was published in 2006 by Schifrin et al. From the reading for today, you learned that upon entering menopause, several women experience decreased sexual drive and arousal. The medical term for this condition is Hypoactive Sexual Desire Disorder. I'll refer to it as HSDD from now on. By medical definition, HSDD is decreased sexual activity that causes distress. In the reading, they also mentioned that hormonal therapy is used in order to treat menopausal symptoms in women, and this is often supplemented with testosterone in order to alleviate the symptoms of HSDD. This study was specifically focused on that testosterone supplementation. The purpose of the study is to examine the efficacy and the safety of the testosterone patch for treatment of women with HSDD. This is in fact the first ever clinical trial to look at this treatment in naturally menopausal women who are also on concurrent hormonal therapy. So by naturally menopausal, I mean that without surgical removal of the ovaries. Let's take a look at the methods. Participants were 549 healthy menopausal women recruited from across Canada, the U.S., and Australia. Now, there were several criteria for participation. 1, women had to enter menopause naturally. 2, they had to have been on menopause for at least 1 year. 3, they had to have been on hormone therapy for at least 3 months. 4, they had to have been in a stable monogamous relationship with a sexually functional partner for at least 1 year. And finally, they had to have had HSDD. Participants were randomized into a group receiving the placebo patch and then into a group receiving the testosterone patch. This patch was placed right on above the abdomen as shown in this picture. It was placed there for a total of 24 weeks. Now, the testosterone group received 300 micrograms, not kilograms, of testosterone per day for the total of 24 weeks. The placebo group did not receive anything. Sexual activity and sexual function were assessed using self-reported questionnaires, pre-treatment and post-treatment. I'll first explain the sexual activity log, describe its results, and then move on to the next questionnaire. The sexual activity log determines sexual frequency of 3 parameters: satisfying sexual activity, total activity, and orgasms. Let's take a look at the results. Here are the results across 4 weeks, or about a month. On the x-axis, we have total sexually satisfying episodes, orgasms, and total sexual episodes. On the y-axis, we have mean number. Now, this is a stacked graph with baseline in blue, placebo in pink, and testosterone patch group in green. This means that the blue bars indicate baseline means, and then the volume of the green or the pink bars indicate increase from that baseline. So the total bar of green plus blue or pink plus blue indicate the total number for the placebo or the testosterone patch group. P-values were statistically significant and showed that the testosterone group experienced improvements in all parameters relative to the placebo group. Now, on to the interesting part is the numerical values. You're probably all wondering, well, how many orgasms does a menopausal woman have with HSDD? And as you can see, it's really not that many. So this is across a month. So if we look at orgasms, they're only having about 2.5 orgasms in a month. And then they're having only about 2.8 satisfying sexual episodes in a month. They also have a total of 5 sexual episodes in a month. In the testosterone patch group, we see that there are increases from this baseline level. So in satisfying sexual episodes, testosterone group experiences 2 more of these episodes per month. They experience about 1.5 more orgasms per month, and they experience 1 more sexual episode per month. So although these results are modest, it does show that the testosterone patch group is having more sex, but that the predominant effect is that this sex is more satisfying. The second questionnaire was the profile of female sexual function, and this assessed feelings of sexual function and activity based on these 7 domains. We have sexual desire, sexual arousal, sexual orgasm, pleasure, concerns, responsiveness, and self-image. Here are the results for this. We have the parameters of sexual function on the x-axis and mean change from baseline this time on the y-axis. So it's not actually mean number like the past graph, it's mean change, and the percentages just designate percent changes. In black is placebo, and in white we have testosterone group. I'd like to point out 3 of these categories which are important. So relative to placebo, for the category of sexual desire, the women on the testosterone patch had a 40% increase of sexual desire from baseline, and they had a 55% increase of sexual arousal from baseline versus a 29% placebo effect. Also, for decreased concerns, testosterone patch women had 44% less sexual concerns versus 21% in the placebo group. This indicates that there is an improvement in sexual function with the testosterone patch group. However, there is a significant placebo effect, as we see the black bars are quite high. I think that this may be due to the subjective nature of this survey compared to the objective nature of the previous survey, for which there is no placebo effect. To summarize, the testosterone patch is associated with increased sexual activity, improved sexual function, and alleviated personal distress in women with HSDD who are naturally menopausal. Some limitations were that the researchers did not distinguish by age. Does a 40-year-old and a 70-year-old have the same sexual function? Probably not. Also, long-term safety was not assessed, and this is key for FDA approval, which I'll talk about later. Despite these limitations, this study has enormous biological significance. The testosterone patch is a potential treatment option for a major concern among postmenopausal women and can have significant effects on the improved quality of life of these women. From an evolutionary perspective, we know that humans are unique in that we have a lengthened post-reproductive lifespan. In Sonali's presentation, she talked about the grandmother hypothesis, and this is essentially to summarize when grandmothers or post-reproductive women will alloparent their grandchildren in order to improve their reproductive success. So non-reproductive sex during this period is not adaptive. Therefore, decreased testosterone levels and decreased sexual drive post-reproductively is essentially an adaptation. And the testosterone patch is used to kind of counteract this adaptation that has been created in us by evolution. Future directions would be to look at the long-term safety effects. Are there potential cardiovascular or breast cancer risks later in life with this testosterone patch? There's actually a testosterone patch on the market in Canada called Intrensa, and it's been available there since 2002. However, the U.S. has not approved it. The FDA in the U.S. has not approved it because they don't know about the long-term safety effects yet. So this would be a next step. To conclude, this was the first ever clinical trial to show that the testosterone patch improves sexual function and increases sexual activity in naturally menopausal women experiencing HSDD. Thank you.